Today, I am privileged to speak with one of our most important allies, Dr. Michael McKee. Dr. McKee is a tenured professor at University of Michigan Medical School and is a board-certified physician in family medicine. Due to his hearing loss, his passion is understanding the state of disability health and how we can redesign our healthcare system to be truly inclusive for patients with disabilities. Mike's passion is seen in his wide-ranging contributions, including clinical and research work, as well as medical and community health education involving deaf and hard of hearing populations. Dr. McKee is the former president of the Association of Medical Professionals with Hearing Loss. So again, Mike, thanks so much for meeting with me today.
Thank you so much, Peggy. Appreciate the invitation.
So we have a lot of interest in electronic health records, and I know that's something that you have been hard at work at. Um, we have talked to a lot of our advocates who are very interested in the idea of the fields that capture a patient's hearing status and the aids and services that will make communication effective and safe, that they be visible in the electronic health records. So I guess my first question is, what do you think is the sort of overall impact on providers? And I mean all of the providers in the continuum of care, the nurses and the schedulers and the lab people and the physicians and everyone else. How does having this information readily available to them impact their work?
Yeah, thank you for that question. So our electronic health record, we use Epic, which is the largest electronic health record supplier in the U.S. We do have here at University of Michigan Medical School and also Michigan Medicine, which is really the healthcare side of things. They did pay for some additional ability to modify the electronic health record. So personally, I do feel it is incredibly valuable for clinicians, the healthcare team, and even for patients and caregivers to document necessary information for what they would like us to know. Obviously, I have different reasons for making sure that we capture the disability related information. I have really been a big proponent of making sure that we're proactive in meeting the needs of individuals with disabilities and their healthcare needs. So, how do we do that? We need to know who these individuals are. We need to know what type of disability they have and get the type of disability, but even more importantly, what kind of accommodations or needs do they have in order to make the healthcare visit more accessible? So that does many things. It not only helps to inform the healthcare team who they're going to see, but it allows us to also understand what kind of accommodations or modification to the visit that's going to be required. Obviously, this is the right thing to do, but it also, more importantly, we have to understand that there are medical legal aspects that we have to follow. We have not done a good job. And so, again, this is a big driver for a lot of the healthcare inequities. And that is no different for individuals with hearing loss, deaf and hard of hearing, even deafblind. So having that information captured, documented, really starts the process. So the identification, just the very first step. But it is a big step that unfortunately has not really occurred widely across healthcare systems. So we're excited that we have this tool implemented.
Thanks for that explanation. We have been talking a lot about where are the barriers to communication access, and we
Mhm.
think that one of them is really not, I always say it's not unlike what happens at the Thanksgiving dinner table. A person might know you have a hearing loss and not appreciate what that means in a person's life, the lived experience, especially in a high stakes
Mhm.
situation. So I, I'm wondering if you think that this tool actually has the potential to raise awareness across the provider groups.
I do believe it does. So there was one situation where we had an old study and really trying to prompt clinicians, family medicine clinicians to active individuals, older adults if they had a hearing loss. So, unfortunately, screening for hearing loss is not widely implemented. So this is just a tool, a component of our overall package that we offer here. And one clinician really kind of remarked to us that I just didn't really act because I didn't feel it was important. And when they ask the individual, do you think you have a hearing loss? And the individual said yes, it really just opened up a wonderful conversation. And she realized how important addressing the hearing loss was. And she said, I had no idea. And it wasn't until being prompted really allowed me to understand that that was the most pressing issue, not on the other health conditions that she obviously was showing up for. So that's just an example. Obviously, the tool that we implemented was really spearheaded by my former patient who has now passed away. But he was really the stimulus for this. He got incredibly frustrated. He had multiple disabilities, and he would go to different specialists, different offices, and he felt, why can't you guys understand who I am? Why can't you just document what type of disabilities, what kind of needs I have, what kind of accommodations I require? And so he had really unfortunate experiences where even being a wheelchair user with communication barriers, he had communication breakdowns. He was also taken out of a wheelchair, put on the floor to try to weigh him. So those kind of things really should have been avoided.
Yeah.
So that's why it's important. I do think it really helped our clinical team understand who the individual was. And I think we're starting to do a better job. I think we still have some second steps in making sure that the accommodations are implemented in a timely fashion. Also, it's important to understand that clinicians are absolutely terrible in assuming and understanding what would make the healthcare visit accessible. So this is really a team decision. Often the patients are the expert. And so like you're alluding to the Thanksgiving dinner, it would be nice if we can act and say, hey, we know this is a big group. The table, maybe the shape of it, or maybe positioning that individual or even just some modifications, raising your hand so people know who's talking next. That's really no different here in the healthcare setting too.
Really helpful because one of the things we're trying to do, I mean, we have two mindsets about this.
Yep.
The first is that the latest figure that we heard in terms of the number of people in the United States with hearing loss is 70 million. That came from Johns Hopkins.
Mhm.
And so one day we were talking, Tony and I were talking, we said, what if 20% of that number um, always filled out a communication access plan and submitted it? Always just had a conversation, a collaboration, an
Mhm.
attempt to collaborate with providers and explain the experience of hearing loss. Would it make a difference? Would it actually create systemic change? So that's sort of one thing that we're going for.
Mhm.
And we're hoping that we can help people do that skillfully and for the long game. On the other hand, my final question for you is there any lesson that you've learned about what your experience can bring to the table in terms of motivating non-patient stakeholders to take this on and get it done?
To me, I think probably the most important lesson, and one that I have also understood and embraced, is that it requires a team to really push things forward. You need the patient voices. You need, having the community organizations also support. So this idea was also largely dependent on the Council for Disability Concerns. We engaged them. We wanted their feedback and really getting the healthcare players, stakeholders to understand the importance. The reality is that you really do need champions to push this forward. There's not necessarily for most healthcare systems a allocated or dedicated individual to do this. And so, a small group of us have really just said, this needs to happen, and we're going to do everything we can to make it happen. And it really required a team to kind of support each other, keep pushing it forward. And, I also kind of chuckle and sometimes we move forward and then we ask for forgiveness later. There are certainly times where I know we had some pushback for certain people saying, well, I don't know if I want this opened up to ask about disability type and accommodations. What if the accommodations are not reasonable or they're expensive? And I always argue we have to do it regardless. But we also did a study and surveyed over 500 individuals to learn before we widely implemented this. And the reality is that most accommodation requests are pretty minor. They're
Yeah,
reasonable. It's very seldom you have something that could be
yeah,
a little bit more expensive.
yeah,
And even then, it's a healthcare system. We have medical legal responsibilities too.
yeah,
So I often use that study to kind of push back. Um, but sometimes you just need to go ahead, take that leap.
yeah. Ask forgiveness and
Yeah.
not permission. Thank you so much for your time. I know you're very busy. You've been seeing patients all morning and goes to competing needs in healthcare. But we really appreciate your insight. We've learned so much from you.
Well, I appreciate the partnership. Yeah. Thank you.